How AI ready are you? Begin or advance your knowledge with the case based courses in the RSNA Imaging AI Certificate Program. Gain the skills and confidence you need to meet the future of medical imaging through our foundational, advanced, and new emergency certificates. Streamline clinical workflows, accelerate your career, and enhance your earning potential. Learn more at rsna.org/AI-certificate.
Welcome to this special edition of the Radiographics Podcast, celebrating both opening day for Major League Baseball on March 28th and National Baseball Day on April 22nd. I'm Jennifer Weaver, a musculoskeletal radiologist at the University of Texas Health Sciences in San Antonio. Today, I'll be discussing the article, Shoulder and Elbow Injuries in Adult Overhead Throwers, Imaging Review, by Dr. Goes, Flores, Dahmer, and Wang, published in December of 2023. This article reviews the osseous and soft tissue injuries common in overhead throwing athletes, offering insights into anatomy, biomechanics, and imaging findings for improved diagnosis and management of these injuries. Overhead throwing injuries are common across various sports, often affecting the shoulder and elbow. Baseball, swimming, softball, tennis, and volleyball are just a few examples where such injuries are prevalent. The abundant forces and rapid shifts in joint position involved in overhead pitching can lead to a variety of unique injuries to the shoulder and elbow stabilizers. A study examining North American professional baseball players from 2011 through 2016 revealed that 17% of approximately 4,000 injuries involved the shoulder, primarily affecting pitchers. Similarly, data from the Major League Baseball Health and Injury Tracking System reported around 3,200 elbow injuries between 2011 and 2014, with pitchers being the most susceptible group. The authors start by outlining the throwing motion, which in baseball involves a continuous process known as the kinetic chain, comprising 6 phases: wind-up, stride, cocking, acceleration, deceleration, and follow-through. These phases are consistent across throwing activities, with minor variations depending on competition level and throwing style. This process requires coordination between torso, lower extremities, and arms. During the wind-up phase, the body shifts its center of mass from both legs to a single leg stance, imposing minimal stress on the elbow and shoulder. The shoulder ends in internal rotation and abduction, while the elbow remains flexed. Stride, the second phase, begins with separating the arms to approximately 180 degrees and ends at foot strike, with the shoulder beginning external rotation and horizontal abduction. Elbow muscles control motion, with the elbow extending in the first half and flexing in the latter half. By foot strike, the elbow flexes between 80 and 100 degrees. The third phase, cocking, begins at foot strike and ends with the shoulder reaching maximal external rotation. During this phase, proximal muscles rotate and extend, while distal muscles externally rotate and abduct the shoulder and flex the elbow. The scapula elevates and rotates upward to prevent impingement. As the shoulder externally rotates, valgus forces are exerted at the elbow, putting significant stress on the medial elbow structures, particularly the ulnar collateral ligament. The conclusion of this phase, marked by maximal abduction and external rotation of the shoulder and valgus torque on the elbow, is often referred to as the critical moment, as it can lead to both adaptive and pathologic changes in both joints. Acceleration, the fourth phase, occurs between maximal external rotation and ball release. During this phase, the shoulder swiftly transitions from external rotation to horizontal adduction and internal rotation, while the elbow rapidly extends from 120 degrees of flexion to nearly 25 degrees of flexion at ball release. This phase is brief but intense, representing the shortest and most forceful segment of the pitching motion. The fifth phase, deceleration, commences at ball release and concludes with maximal shoulder internal rotation and elbow extension. This phase subjects the glenohumeral joint to the highest loading as the shoulder attempts to safely decelerate the forward motion of the arm. The scapula provides stability while the humerus swiftly transitions from external to internal rotation. Muscles like the biceps, brachialis, and elbow flexors work to prevent rapid elbow extension and forearm pronation, thus averting impingement of the olecranon on the olecranon fossa. Throughout this phase, an eccentric elbow flexion torque is generated to slow down elbow extension. Lastly, the follow-through phase begins with the shoulder in maximal internal rotation and concludes when the thrower achieves a balanced stance. During this phase, energy dissipates from the throwing arm, and the shoulder internally rotates and adducts while the elbow flexes. Simultaneously, the trunk rotates forward and the arm crosses the body. The authors next discuss specific shoulder pathologies prevalent among throwing athletes. First is glenohumeral internal rotation deficit, characterized by a loss of internal rotation necessary to achieve maximal external rotation. Initially, this deficit may be adaptive and symptom-free. However, symptoms can arise when the loss of internal rotation surpasses the gain in external rotation, resulting in a deficit in the overall range of motion. This deficit is considered the chronic cause of the condition known as dead arm, marked by a decline in pitching accuracy and velocity. A primary cause of glenohumeral internal rotation deficit is believed to be severe contracture and thickening of the posterior inferior recess and capsule. Additionally, factors such as humeral retroversion and muscular stiffness due to repetitive strain are considered significant contributors. What do we see on imaging? On MRI, we can see thickening of the posterior inferior glenohumeral ligament and axillary recess capsule. MR arthrography studies have shown that throwers tend to have a thicker labrum and posterior inferior capsule, along with a more shallow posterior capsule recess angle compared to non-thrower controls. Another shoulder injury common among throwers is the Bennett lesion, also known as a thrower's exostosis, characterized by extra-articular ossification along the posterior inferior glenoid rim. While often asymptomatic, pain may occur due to non-union of fragments, acute avulsion of the ossification, or irritation of the capsular and axillary nerves. In some cases, infraspinatus muscle atrophy may develop from suprascapular nerve impingement by the exostosis, particularly in pitchers and volleyball players. There is ongoing controversy surrounding the Bennett lesion, necessitating clinical correlation for diagnosis. What do we see on imaging? Axillary, Stryker notch, or modified Bennett radiographs can show the ossification. CT, with a sensitivity of 98% and a specificity of 97%, is an effective in identifying Bennett lesions and assessing for fragmented lesions or posterior glenoid dysplasia. On T2 weighted or proton density weighted MR images, the Bennett lesion appears as a low signal intensity bump with elevated periosteum along the posterior inferior glenoid, while T1 weighted MR images can reveal early thickened subperiosteal tissue before mature mineralization occurs. The authors then discussed posterior superior internal impingement, characterized by abnormal contact between the undersurface of the posterior supraspinatus or anterior infraspinatus tendon and the greater tuberosity and posterior superior glenoid and labrum during the late cocking phase. Clinically, this is identified by pain without apprehension in the abduction external rotation position, which is relieved by a posteriorly directed force. The cause of posterior superior internal impingement remains debated, with theories including altered biomechanics due to a stiff posterior inferior capsule and anterior instability. What do we see on imaging? On MRI, findings may include posterior humeral head cysts, cortical irregularities, articular-sided partial thickness tears of the posterior supraspinatus and anterior infraspinatus tendons, and tearing of the posterior superior labrum. MR arthrography with A-bear positioning can confirm undersurface cuff tears by lifting the tendon from the humeral head. The authors next discuss scapulothoracic muscle dysfunction, a fatigue-related condition that disrupts normal humeral and scapular alignment during acceleration, contributing to symptoms of posterior superior internal impingement. Clinically, these patients exhibit asymmetric malposition of the scapula in the dominant throwing shoulder, with one shoulder typically positioned lower than the other. Depending on the type of dysfunction, this condition may be associated with either labral or rotator cuff pathology. Slap tears and pseudoelaxicity are common findings in throwing athletes. Shifting of the glenohumeral contact point increases the risk of labral tearing, particularly the peelback injury of the biceps labral complex. In the abduction external rotation position, the posterior inferior glenohumeral ligament is positioned beneath the humeral head. The contracted posterior inferior capsule levers and pushes the humeral head posterior superiorly, causing the biceps tendon to twist. This action forces the posterior superior labrum and the biceps root to rotate medial to the glenoid, predisposing the biceps anchor and labrum to separate from the bone, resulting in a type 2 slap tear. This condition can lead to acute dead arm syndrome. What do we see on imaging? On MR arthrography, this peelback injury may be visualized best in the A-bear position. Moving forward, the authors address anterior shoulder injuries. Among baseball pitchers, subscapularis tears frequently occur within the inferior half of the muscle. This occurs due to excessive external rotation and cross-body abduction during the late cocking phase, stretching the inferior fibers across the anterior glenohumeral joint and predisposing the subscapularis muscle to failure. As the humerus internally rotates from late cocking to early acceleration, the subscapularis undergoes internal rotation and forward acceleration. In adolescent throwers, lesser tuberosity avulsions may occur. What do we see on imaging? Axillary radiographs and CT can reveal lesser tuberosity rate avulsions, while MRI is valuable for evaluating subscapularis muscle injuries. The final shoulder injury discussed involves injury to the latissimus dorsi and teres major muscles, occurring during late cocking and acceleration phases. The latissimus dorsi muscle aids in adducting the elevated arm against resistance, pulling down on the humerus and compressing the inferior scapula when the arm is elevated. Similarly, the teres major muscle contributes to adduction, extension, and internal rotation of the humerus. These injuries often occur together due to their confluent humeral insertion, synergistic muscle action, and similar muscle vectors. If these injuries are suspected clinically, larger field of view T2-weighted fat suppressed sequences should be obtained in the shoulder imaging protocol. The authors next focus on elbow injuries in throwing athletes. Valgus loads during acceleration create significant tensile forces at the medial elbow, leading to ligament, tendon, nerve, and bone injuries. The ulnar collateral ligament serves as the primary static restraint to valgus stress in the elbow and is commonly injured in overhead throwers. The anterior bundle of the ulnar collateral ligament originating from the anterior-inferior medial epicondyle and inserting on the subline tubercle of the ulna is particularly crucial. It provides valgus restraint at 30 to 100 degrees of elbow flexion, predominant during the throwing motion. This anterior bundle consists of both anterior and posterior bands, which display different strain and injury patterns depending on elbow position. The abnormal ulnar collateral ligament may present with thickening, attenuation, ossification, or tears, either partial or complete. The anterior bundle is the most commonly injured, typically occurring in the mid-substance. Distal tears often involve the anterior band, while proximal tears more frequently affect the posterior band. What do we see on imaging? Radiographs may show heterotopic calcification in the expected location of the ulnar collateral ligament with chronic injury. Avulsion fractures of the sublime tubercle can also occur. The ulnar collateral ligament is well visualized on ultrasound, although ligament thickening with hypoechoic foci and calcifications can be observed as adaptive changes in pictures and should not be mistaken for pathology. Valgus stress ultrasound can be utilized to assess for laxity. MRI has nearly 100% specificity, but only 57% sensitivity for detecting ulnar collateral ligament tears, while CT arthrography offers 86% sensitivity and MR arthrography provides 100% sensitivity and specificity. However, it's important to note that an abnormal appearance of the ulnar collateral ligament on imaging may be adaptive rather than pathologic in asymptomatic pictures. In symptomatic patients, a partial tear at the distal attachment of the anterior bundle appears as a characteristic T sign on coronal MRI images, caused by fluid or contrast material interposed between the ligament and the sublime tubercle. However, one must be cautious in differentiating this from the normal 3 to 4 millimeter separation between the distal insertion of the anterior bundle and the sublime tubercle, which can be observed in approximately 50% of the general population. Previously, injury to the ulnar collateral ligament was considered career-ending for professional pitchers. However, with the rise of ulnar collateral ligament reconstruction, commonly referred to as Tommy John surgery, more elite pitchers are now returning to play. Since the first surgery in 1974, multiple newer techniques have been developed. What do we see on imaging postoperatively? On MRI, an intact ulnar collateral graft typically displays low to intermediate signal intensity on both T1 and T2 weighted images with possible thickening, especially proximally. However, up to 25% of intact grafts may exhibit intermediate T1 signal intensity and intermediate to high T2 signal intensity. A degenerative graft will show diffuse intermediate signal intensity on T1 images and mild increased signal on T2 weighted images with indistinct fibers. While normal grafts can be irregular, they should not appear wavy. Contrast may extend between the distal aspect of the reconstructed ulnar collateral ligament and the sublime tubercle due to the tunnel location 3 to 4 millimeters distal to the articular surface, a phenomenon known as the false T sign. Medial epicondylitis is prevalent among overhead throwing athletes, characterized by non-inflammatory tendinosis or degeneration of the flexor pronator mass. This condition results from repetitive eccentric loading of the wrist flexion and pronator muscles, combined with valgus overload at the elbow during late caulking and early acceleration phases. What do we see on imaging? Radiographs typically appear normal, although calcifications may occasionally be observed at the humeral origin of the common flexor tendon, the pronator teres, and the ulnar collateral ligament attachment. Ultrasound reveals hypoechoic areas without fiber discontinuity or intratendinous calcifications in the case of tendinosis, a focal anechoic area with partial thickness fiber discontinuity with a partial tear, or a full width tendon gap or tendon non-visualization with a complete tear. MRI often shows common flexor tendon thickening, increased T1 and T2 signal intensity, peritendinous edema, tendon tears, partial ulnar collateral ligament tears, and medial epicondylar marrow edema. Ulnar neuropathy is another concern in overhead throwers and can stem from entrapment, trauma, chronic irritation, or compression. What do we see on imaging? Ultrasound can reveal a swollen hypoechoic nerve with loss of fascicular architecture. On MRI, increased nerve signal intensity on T2-weighted fat-suppressed images may be observed, although such findings can also occur in asymptomatic elbows and must be interpreted in conjunction with clinical symptoms. Additionally, cross-sectional nerve area can be measured 2 to 3 centimeters proximal and distal to the cubital tunnel. Some propose nerve cutoff size values of 9 millimeters squared on ultrasound and 10 millimeters squared on MRI, while others suggest a cutoff value of 11 millimeters squared for both modalities. Dynamic ultrasound evaluation can also be utilized to assess for nerve subluxation or dislocation. Finally, the authors cover posterior medial impingement and valgus extension overload syndrome, both occurring due to valgus forces from late cocking through deceleration phases. Posterior medial impingement occurs when the olecranon wedges into the olecranon fossa, often exacerbated by ulnar collateral ligament insufficiency, leading to posterior medial impingement. Valgus extension overload syndrome, also known as pitcher's elbow, involves a combination of elbow extension and varus torque that counteracts valgus stresses, resulting in medial tension, lateral compression, and posterior olecranon shear forces. What do we see on imaging? Osteophytes can be seen at the posterior olecranon tip and posterior medial olecranon on radiographs and CT images. Fractured osteophytes or intra-articular bodies may be present in the olecranon fossa. Chronic mechanical overload can lead to osseous changes such as subchondral sclerosis and cortical thickening. MRI may show an ulnar collateral ligament injury along with fat pad scarring, medial triceps insertional tendinosis, posterior medial recess synovitis, and kissing osteochondral lesions of the posterior medial olecranon and trochlea. However, these findings should be correlated with clinical symptoms, as they can also occur in asymptomatic elbows. Olecranon stress fractures may also occur due to repetitive triceps contraction during follow-through or from repetitive olecranon impingement. What are the recommendations for imaging in throwing athletes? As usual, imaging should begin with radiographs. Next, MRI is the preferred modality to assess for soft tissue injuries in the shoulder. MR arthrography may be helpful to evaluate for partial thickness, articular-sided rotator cuff tears, as well as posterior superior labral pathology. MR arthrography can also be useful in assessing glenohumeral internal rotational deficit and posterior superior internal impingement. MRI is the preferred modality for soft tissue evaluation in the elbow. MR arthrography has a higher sensitivity and specificity than conventional MRI in the evaluation of ulnar collateral ligament tears and can be helpful in the postoperative setting following ulnar collateral ligament reconstruction. Valgus laxity can be evaluated with dynamic stress ultrasound evaluation. I hope you found this article review on shoulder and elbow injuries and overhead throwing athletes informative. Understanding anatomy, biomechanics, and imaging findings allow us to diagnose these injuries effectively. A heartfelt thank you to the authors for this wonderful article. I encourage everyone to check out their beautiful illustrations and images. Thank you for tuning in.